tonight's session is obviously about the GP supervisor in difficulty. It's a bit of a new one in terms of there's often a lot of sessions that are run around RTOs about the registrar in difficulty, and we thought that it was about time that we paid a bit of attention to supervisors that might be struggling as well. So thank you for attending. As we do normally, we'd like to acknowledge the traditional owners of the land on which we meet tonight and pay respects to their elders past and present and their families. So thank you for joining us around the country. Now, in terms of the webinar housekeeping, for those of you that haven't been to a GPSA webinar before, we have got you very on purpose muted, and that's because with the sheer volume of participants, trying to get 100 people speaking at once or asking a question could be very difficult and distracting for those of you that want to listen, and just makes for a disjointed webinar. So thank you for joining. You will notice down the bottom left-hand corner something that looks like, let me just show you, the chat box. The flashing arrow there shows you the chat box. We do want you to ask questions, so please use the chat box to both talk to your fellow participants and also to ask the questions that you would like. In the background, you won't be able to see it, but we will be marking the questions red and green based on what you've asked and what has been answered. So we will try to get around to all of your questions as efficiently as we can. If we don't get to your questions, though, we always have a frequently asked questions, and this session is recorded. So we will put the recording available on our YouTube channel and also the frequently asked questions. Now, as promised in the promotion of this webinar, we have the guide that has been developed by Denise for this session, and that's available down the bottom right. If you look at your screen, you'll see a little folder. If you click on that folder, you will be able to see a range of resources. Some of them are links, and there is also one PDF document which you can download today. That is the very first time that that guide has been available to the public, and that will go up on our website and be downloadable as with all of our resources as GPSA pursue a FOMED, that's free open access medical education resources online. Now we will be recording this webinar. I've explained how to do to ask a question, so please do. An interactive webinar is a lot more interesting than one that is not. And without any further ado, I would like to introduce Denise Finlay, who a number of you will know from the RTO landscape, has been around for a very long time. Thank you very much, Denise, for joining us. And if you would like to give them a run through, those that have not been around this space and perhaps don't know you, that would be great.
Okay, thank you very much, Glenn, and thanks very much for inviting me to be involved in the development of the guide and for this webinar. I was with both Victoria as a registrar years and years ago. I've been a medical educator, and I've been a director of education over in WA for a while. So more recently, I've left the RTO landscape a little bit more, and I'm working as a director of education and clinical training with an organisation in WA called Silverchain that's doing some community training with RMOs. But I am doing some other distance work with other RTOs. So I do know a little bit about the regional training organisations and where they've come from and where they're going to. And tonight, before we really get started on what I'm going to be covering, I just wondered, with those of you who were there already at 35, whether you would fill in a short poll on where in the country you are, because you've just worked out that I'm in WA. So do we have the poll there, Glenn?
Strangely enough, it's not coming up.
Oh,
we will populate
okay.
that if you can.
No, that's fine.
Continue.
That's fine. What I wanted to do was to do a very, very brief overview of the supervisor role and looking at the supervisor at risk behaviours, but spend a little bit more time on the challenges particularly the protective factors and managing the supervisor in difficulty. And I'm sure we can talk for a long, long time, but let's see how we go. Now, it will come as no surprise to you all that being a supervisor is a role that can be complex, very diverse, and quite challenging. And here are all of the hats that you might wear, plus a few more. And you can see that that does make it for a diverse and complex process. I've showed it as hats, but Health Workforce Australia asked all of the health professions what did it mean to be a clinical supervisor, and came up with a diagrammatic representation of 3 domains of clinical supervision, safety and quality and organisation. And they certainly mirror the RACGP and ACRM standards, which of course are much more in detail around what it is to be a clinical supervisor. Many of you will know Susan Wern, who works with the AGPT and is a GP supervisor herself, and has done a thesis on looking at supervision and the Registrar Educational Alliance. And I think this is another really good diagrammatic model of those hats in a different way. So the hats, the domains that that we've seen before, and then these. And you can see that you've got a range of things happening here, the assessing, the summarising, the well-being, all of those. I think that when you look at it, in a sense, these concepts of what it is to be a supervisor do put a huge expectation on supervisors to be on a pedestal and a little bit of a superhero. And there's nothing wrong with having superheroes, and we do acknowledge that supervisors are in fact the cornerstone of training and general practice. But the expectations are really high, and if you start looking at things like the RACGP and ACRM standards, the amount of things to be covered are huge. And so I think it does create some difficulty for supervisors. And what's also interesting, and we'll cover it a bit later, is being a GP is stressful enough, then you add being a supervisor as well, it does put you at a higher risk. So what I wanted to do is to just get you to think about what would you see in a supervisor who was starting to run into difficulty? What behaviours would you identify? And so, if you can see that chat box down the bottom, I'd invite you to think about some of the behaviours that you would identify in a supervisor who might be in difficulty. So I'll stop talking for a bit to see if we can get any cranky. Fantastic, Claire. And if you just watch, you can see bad language, when you finally do get home, unapproachable, not engaging with the registrar, arriving late, angry. You can see there's a lot of emotional language in there. Not organised. Not sure what avoiding. So avoiding the registrars and people, I suspect. I think that one about being very fed up with the attitude of a difficult registrar is a really interesting one. non-ironed clothes. I must admit I don't get to see that, and I certainly didn't as a Director of Education, but that's certainly the case, that you could see that. Thank you very much. I'm sure you could think of a lot more. When I looked at the literature, and what I did was I looked at the literature across most of the health domains in supervision, not just medicine, and also looked a little bit at education. It was really dividing these behaviours into probably 3 areas. And it will come as no surprise to you, the 3 areas. Ineffective supervision, so some of the things that you were talking around about the teaching or not being available and accessible. Things called disruptive behaviours, which are questionable practices, bullying and harassment. We'll cover that a little bit more. And then, of course, at the very other end, the notifiable conduct, that which we're all mandated to report. And it really is a spectrum of behaviours. And often it isn't a once-off behaviour, as you would well know, in identifying the supervisor risk. It's usually what you would call enduring or consistent, repetitive behaviours, or there's an escalation there. But importantly, for some of the disruptive behaviours or notifiable conducts, of course, one thing happens, that's actually reportable, or that's actually considered harassment. So it does depend on the level, but generally you've got that whole spectrum of behaviours. In terms of ineffective supervision, I think that there's about 5 different styles there, and I'll give you just a few examples so that you can go, oh yep, okay. The Poor Supervisor Registrar Alliance, so you might see, and you've described that a little bit, a rigid or critical or distant, distracted supervisor, someone who isn't taking an interest in the registrar's interest, is often irritable or annoyed. But in that also is things like not giving a sense of their own shortcomings, treating the registrar as a student rather than a colleague. You'll see that happening and being talked about. In the unsafe learning environment, the sort of examples that you might hear about is this feeling that there's no sense of safety to reveal a registrar's doubts or fears about their competency, or they're feeling threatened, or they actually retaliate if they see the registrar knowing a little bit more in one area, and often blaming a registrar if they're not adhering to guidelines. Yeah, and I think that's always a challenge, as Maggie said, is the complaints from a registrar may not always be accurate, but equally, as we'll see with some of the challenges, sometimes they are too. And it's a real challenge. Unsupportive environment, so those things that you were talking about, them not being available or accessible, actually ignoring their need for emotional support in that new environment of general practice. Putting service delivery above education. So you can see that many of these are around the teaching supervision elements. Lack or poor quality teaching, and that's always a challenge, as you would know, is sometimes there is a lack of supervision or structured teaching or no feedback, but invariably you'll also hear about how what the registrar thinks is teaching is not necessarily what you're thinking is teaching. They are very sensitive, I think, to supervisor mood. The other one under sort of poor quality teaching is that whole concept of being trainer centre. So often if you have a supervisor who's getting very rigid teaching structure and got fixed views about what the learner has to learn, is pretty black and white and does a fair interrogation, all the things that I'm sure you don't do, but they're the sort of things you start to see happening. Being what they call registrar-centred is not leaving them alone. So that lack of quality teaching is not letting them be alone in their own learning. And feedback is, of course, a whole topic in its own right. And in any supervisory relationship, the quality of the feedback is really, really important. So you'll often hear about there being little or no feedback, or it's not specific or timely, that if they're doing direct observation, they actually interrupt during a consultation. And failing to send in assessments or paperwork, etc. So they're the sort of behaviours you might hear about. In terms of disruptive behaviours, it's a term that the Canadians tend to use quite a lot, and I think it's a nice term. It's where there's inappropriate conduct in word or action that interferes with or has the potential to interfere with quality care delivery. And so it might be very much an active behaviour, and you talked about grumpy, difficult people, but equally it can be passive. It can be choosing not to do things in a way that does interfere. So it can be both active and passive. And it can be unethical or questionable behaviour, bullying, or it can in fact be harassment. When I asked previous supervisors about unethical or questionable practices, it's interesting what they came up with. It was about inappropriate labels, making unprofessional comments, involving the registrar in conflicting dynamics in their work environment. Someone even suggests coming back with alcohol on their breath, and apparent Medicare fraud and inducing the registrar to do the same. But I think that's getting to that other end. With bullying, and I'm sure you're all aware of this because there has been a guide put out on bullying by GPSA, but it's repeated unreasonable behaviour towards a worker which creates a risk to health and safety. And there are 3 essential elements. Well, there's 4 I've got up there. There's a power inequity. You basically can't have bullying if people are of the same level of power. That's conflict. Thanks, Shelley. But bullying has a negative impact on the victim. It's persistent and it's subjective. And that's the challenge, because it is subjective. There's no easy objective way to do it. It is as the victim sees it, being bullied. What it isn't is where you're doing constructive supervision and performance management, because that's developmental and supportive. So it can be quite hard to pick between bullying and that in some people's minds, but they are clearly different. And again, the way you're going to be giving feedback makes a difference. Harassment, as you would well know, is where a person feels humiliated, intimidated, or offended because of particular attributes, their gender, race, disability, and age. And I'm not sure if you're all following the chat, but they are really good points, that this relationship of supervisor and registrar goes both ways, but can become a real problem if it goes with the registrar supporting the supervisor. The important thing with harassment is that whereas bullying tends to be repeated behaviour, harassment can be purely a one-off and needs to be stopped dead in its tracks. So this is one area where disruptive behaviour is not about repetitiveness, but rather once off is enough to be actually called harassment and to be called on. It will come as no surprise, I suspect, to you why we're talking about it quite a lot is because in medicine it's unfortunately quite common. In the US, 91% have experienced or observed gender-based discrimination. That's huge. In the UK, they did a big study and 37% of the doctors were being bullied and 69% observed it. And in Australia, you'll have all been aware of the Royal Australasian College of Surgeons, where 49% of the fellows, trainees and IMGs were subjected to bullying or harassment. It's a really interesting thing, Martin, the whole concept of what is bullying and harassment. Because the more you read into it, the more you discover how much there is going on. And it's not so bad when it's just a once-off, but it's about the repeatedness of it and the escalation of it that causes problems, both for doctors and for patients in the medical setting. And it's, again, we're talking here not about the I'm having a bad day. But when we do come to management, we will have to talk about the fact that sometimes when you're having a bad day, you may actually do something that you do need to get pulled up on. The 2008 survey in Australia of a whole lot of GPs found that, well, actually doctors, and about a third in the survey were GPs, were saying in the last 12 months they'd been bullied, 25% of them. So it's a really important thing to be thinking about and to recognising and to be doing something about. I'm not going to spend much time on notifiable conduct, except to say there are the 4 categories for which we were mandated. And what I really wanted to just flag here under notifiable conduct is just a reminder that all health professionals are mandated, but it's not just people in the same health profession. So if there is notifiable conduct, then registrars, other doctors in the practice, nurses, physios, other health professionals are all mandated to report. It's not medical to medical, it's across the board. So registrars are in this place where they may be mandated if they see notifiable conduct. If you think about the Royal Australasian College of Surgeons and you think that 25% of our colleagues in the last 12 months thought that they were bullied, if you think about your registrars in practices and how sometimes everyone knows this practice, but nothing necessarily happens, what I'd like you to think about and use the chat for is, what do you think are the challenges in identifying and or managing difficult behaviours? Agreed, Genevieve. That whole concept of if I say something, I'm in trouble. Are there any other challenges? That once you say something, that person's going to get defensive? Absolute denial? There might be practice supervisors in the same practice or other supervisors. And I think you're right, where the supervisor's employer, it's really challenging. And it is difficult when they're your employer. Yep. Absolutely. So that whole concept that if I say something, it's not going to be good for me. So you've identified some of those areas. The whole concept that maybe we don't recognise some behaviours, and I think that goes back to something someone wrote before, that, you know, there's a whole lot of this bullying and harassment, you know, how much of it is really there. There's also the late recognition, the belief that the behaviour is actually acceptable or even helpful, support and tolerance, and the possibility of deferring the issue or reversion to previous behaviour. So there's some of the challenges, just really quickly, because I'm looking at the time. Sometimes we don't know what it means to be being bullied or be a bully, and often people don't know that that's what's happening, that that's in fact what's going on. We may not have the feedback, we may not be finding out, so it may go unrecognised. It is much more likely that it's about not just recognising it, it's about how do I deal with it and feeling ill-equipped to deal with it, that it's all too hard. That whole concept that you were talking about saying something that will make it worse, that whole concept of we're in a helping profession, we don't want to trash someone's reputation, nor if they're already feeling a little bit stressed, make it additional stress. And sometimes dealing with it early, informally, means that it might grow if you don't move to formal. That whole concept of it's helpful or acceptable, and it's often called transgenerational legacy. This whole concept of I had it done to me, so I can do it to other people. I had it done to me and it made me a lot stronger, so, you know, it's really good. It's good for you. And then, of course, there's that whole support and tolerance for the behaviour. So everyone just accepts it, because that's how it always was. And it goes a little bit back to what we were talking about before. And as you talked about, there's often that collusion, and it might be the regional training organisation, it might be the practice, it might be the registrar. So you do need to look at it, and you're right. It may be other people in the practice who pick it up and deal with it. So when we talk a little bit further, the really important thing here is about creating a safe environment and creating policies and processes by which people can say something. And then, as I said before, that whole thing of it's someone else's business, someone else's role, I won't do it. And you often even hear that with notifiable conduct and mandatory reporting. And then, of course, someone who you've dealt with and they revert to where they were before. So it's always a real challenge. And it's a real challenge because the behaviours you've identified aren't necessarily what's really going on. They're just the behaviours, they're the symptoms. And so it may be that they have got a lack of support, work commitments, a dysfunctional work environment, broader or training or limited supervisor training. They might actually not have some of the knowledge and skills, and so what you're seeing is a different way of doing it. And the behaviours are saying, I don't know what to do as a supervisor. So the younger supervisor may be in that situation. That whole concept that it has got multiple hats. It is a diverse role. The focus on workforce and having the skills to really manage the good old challenging registrar. And I just want to go back to the knowledge and skills, because there's a fair bit of literature that says keep in mind that being an effective supervisor isn't the same as being a good clinician. There's actually a different set of skills that you need to be an effective supervisor, not just a good clinician. And to be an effective supervisor isn't the same as any of the normal competencies of a teacher. Again, there's some different competencies. Behind all of that, apart from the systems and the education, is the personal. I've highlighted the bottom one, the alcohol and drug dependency, because the Canadian College identified that, in fact, this is yet again another symptom rather than a cause for some of the behaviours. And they said that many of the time doctors are in trouble with alcohol and drug dependency. You usually find the rest of their life is in total chaos and turmoil by the time it's got to that and people are recognising it in the medical field. And I just really wanted to remind you of how much as GPs, let alone GP supervisors, we have our own personal risks. Because, sorry about the cat, we have a situation where in a 2013 survey, what they discovered was from Beyond Blue was that GPs have higher psychological stress compared to the general population and other health professionals. So it's really quite different compared to other. GPs have the same levels of depression, although you'll notice that females are at a higher level than the general population and other health professionals. But scarily, suicidal ideation is much higher. 24% of people in the last GPs in the last 12 months, or doctors I should say, not just GPs. And importantly, separate to that, burnout stands really high for all of us as doctors, with generally 38% having emotional exhaustion, 34% cynicism, and 14% low professional efficacy. So supervisor role is diverse and challenging. Being a GP is challenging and has with it that whole raft of things that go with it. And so that's a really important thing to be looking at. Now, to move on to management, so can we identify and how do we manage it? I think there's two components to management, and the first is what is it that we know that protects us as supervisors, as GPs? And I think these are the things, you could call them preventive. It is interesting, isn't it, that in fact the younger are much more burnt out and stressed. And it may be about peer support, and it may be about the way that you've chosen to do things over time. But if you think about where you are in that list, you can see how high it is. There was no evidence that I could find that says that GP supervisors are more stressed than non-supervisors. And I think you could make an argument one way or the other there. But I don't think there's any literature, certainly, that I came across that said. Now, I see each of these elements as sort of cogs. When one's working well, it helps with all of the others. And I just really quickly want to run through the protective things that have stood out in the literature. So having really clear expectations of what's expected as a supervisor across the board in all health professionals is protective. And you can see that in many cases we've got that. Having a clarity of your role and knowing, identifying and being able to manage potential or actual conflicts is really important. So being proactive about that. For you as supervisors, it's really important that you also have really clear policies or codes of conduct right at the base in the practice. Going back to what we were talking about before, who can the registrar talk to, who might flag these problems? It could be any of the staff, but it's about having that very clearly articulated. Actual choice. The literature's full of the fact that if you choose your own supervisor, there's really good evidence that you feel well supported, and the alliance, that relationship is so much better. And of course, if we looked at all of the literature that has asked you in Australia, why have you become a supervisor, there's a large proportion of it around personal and professional benefits that actually makes it an exciting and interesting place to be. So being a supervisor, going back to that question, may in fact be a protective mechanism if you put your hand up and said, I'd like to do that. And in fact, having registrars who choose their own supervisor by choosing practice may in fact be a really good protective mechanism as well, for this to be a really good relationship and supportive even for supervisors. This area, I think, is a really important protective feature. You really need to have a supportive culture in the practice or the organisation. And let's talk about it from the perspective of the practice. There's lots of literature that says if the practice or the organisation is not supportive, then supervision just doesn't happen that well. And it's very hard for a good supervisor to have a great relationship and to have a good experience for the registrar if that supportive practice isn't there. On the other hand, what's interesting is when you've got a supervisor who's struggling or in difficulty, in fact, a really supportive culture in the practice actually mitigates the effects of the supervisor who's not really managing very well. And in fact, many registrars will have a positive experience because you've got a really good supportive culture. That's right, where general practice is a family, but it's not always family. The other thing that I'd really like to highlight is this whole concept of sharing the responsibility. One of the RTPs looked at what was it that made for a higher quality GP training practice from a perception of medical educators and registrars, and they did a really big study. And what they really found was where you had other members involved and accessible, non-clinical members contributing to teaching, and actually regular structured clinical meetings, you really had registrars having this incredible experience of a high quality GP training. So that supportive culture really makes a difference. It isn't just about the supervisor. And the RSCGP is quite clear about that too in their guidelines, about you being a coordinator, being very important for elements of all of that education and relationship, but it being the whole practice. And I think that that's a really important protective factor, that whole culture sharing the responsibility. You, as supervisors, don't have to do everything. There are some things you must do, but there are, like assessment or giving feedback, but even those things can be shared. So the other that's quite protective is having good support networks. And we've talked about the practice part of the supervision team. So having a supportive culture in the practice and having the team involved is a great support. But having a whole practice that's got a support for all of the doctors across all of the things that are going on is really valuable and will, of course, look after you. Having local supervisor network supports, having an RTO network support with your SLOs, your medical educators, your directors of training, and of course GPSA. Self-care. Interestingly, this same study highly identified that where a registrar thought that a supervisor was demonstrating self-care, that was considered delivering high-quality training as well. So if you can look at it and think, am I delivering, am I looking after myself, then there's a really good chance when you're doing that, that you're also going to be delivering high-quality training because you're in a better place. So to do that, a well-considered, achievable, concrete self-care plan, not sure how many of us do it, our own GP. In the health professions, it is unusual in medicine, but in nursing, psychology, supervision of supervision is a really powerful support for self-care. And I've just raised the question here that maybe there's some real benefit in looking at how we might create supervision of supervision, engaging external clinical supervisors to support us, creating supervision of supervision groups, having meetings of peers and doing peer supervision of supervision. And that's quite specific. That's not, let's all get together and just talk. This is about how are we supervising, how are we managing. And probably the closest I've seen in RTOs is Valent groups. And the supports, the self-care guide's a really good one with the RACGP, keeping the doctor alive. Of course, there's the GP support program for RACGP members and the Doctor's Health Advisory Group. Jacob, you do a Valent group and you do it fortnightly. What do you find valuable about that? Karen, you're right. Self-care is a really interesting one because I think we do use the concept of being time poor. And it stops us from doing this, whereas if we looked after ourselves, we probably would be in a much better place. And I think that that becomes one of those major tensions. And Jacob's flagged with the Valent groups that whole concept of sharing experiences and ventilate concerns. Valent's very much looking often at the doctor-patient relationship, not so much the supervisor-registrar relationship, but it could do that as well. But that might be something GPSA should look at, or could look at, is how do you create supervision of supervision so that we're well looked up, as supervisors you're well looked after and caring for each other. Training, there's no doubt, certainly that higher quality GP training was flagged when it was associated with people who'd undertaken training. Fantastic local men's group. Great, so there's some things happening there. So really important that you're also open to learning from the registrars and others. And coming back to that whole concept of bullying, harassment, disruptive behaviours, really having some training around what is it that makes up those behaviours, that early recognition, and actual skills in what's called crucial conversations. It's a catchphrase, but it's a whole structured approach to saying something and saying it early so that you can keep the disruptive behaviours at the post in a sense. And there's a lot of literature over in the US that has said that when you're done some training in being able, when it's a tricky, challenging and emotional place, to have a crucial conversation makes huge differences to how whole teams function, how everyone functions in their relationship. And just look at those very quickly in terms of the sort of things that are about supervision that you need the skills in, and having those sort of skills can be quite protective. Now, I'm not going to spend a lot of time here, But another really protective feature is being effective in your supervision strategies. And I want to go back to that whole concept of sharing responsibility, because the Educational Alliance is really a supervisor's area. Giving feedback can be true, but it can be shared. A structured orientation can be shared. Being learner-centred is something that everyone should be doing. And effective teaching is not something you have to do. It can be shared too. So many of these effective supervision strategies, if you've got them in place, but you're doing them with a shared responsibility, mean that you're actually looking after yourself and protecting and supporting the whole of the process. So just to flag that Educational Alliance, pretty well all of the literature says this is probably an extraordinarily key element. But there's almost no research in it to say exactly what works and what doesn't. This is what seem to be the factors that make for a really positive alliance. And I'm sure if I asked you to think of them, you'd have come up with most of them. Being learner-centred, higher quality general practice training, really it was about a structured orientation that met the registrar's need, that they worked to develop a learning plan. Now we all roll our eyes at the concept of a learning plan, be it written ones, but many are informal or formal, but if you have a plan with your registrar, that really helps them and helps you. It's again about that defining the boundaries and knowing where you're going. And feedback again, if you're giving feedback within 4 to 6 weeks, if you're doing it all of the time in a constructive and valuable way throughout the term, and you're discussing appraisals and assessments, you are actually creating a very effective supervision strategy. You're giving them support in the issues that are coming up. And if you're doing effective teaching, and here again, I'll just come back to that shared responsibility. You don't have to do it all. In fact, it's a real bonus to be able to share it around. But if you are, remember, it's about learning needs. It's about the teaching actually happening, that it's actually structured, that it's actually regular, that it's evidence-based. They are all things that really make a difference for a registrar. And if you're talking about the one-to-one teaching, you can see this in another study that was done about protected time, using resources like patients and guidelines, follow-up, giving feedback, all the things we all talk about, but very importantly, direct observation. And it's sort of a last dot point, but it is considered a highly effective component for teaching. And again, as a supervisor, that could be by video or direct observation, it's really, really important. But again, that can be shared. And the registrar gets the benefit of different views of things. So many of these protective factors allow you, by almost overlapping them and integrating them, allow you to really look after yourself and not find yourself in the place that we've been talking about. And Bruce, you're right, the difficult registrar is a really powerful motivation to find someone to talk to about. I'd like to suggest that before you get the difficult registrar, that you've got a lot of those support networks. And so even experiencing other people's struggles and working out how they've done things means that you're in a different place. If I were to look at those 7 things, I'm just wondering if there are any in there that you think would be really powerful for you to actually strengthen for yourselves. And if the polls are working now, what I'd like you to do is just pick 1, 2 or 3 areas very quickly. Where do you think you could put a little bit more time on that prevention support that means that you've got a more protective component? While you're still all polling, just going back to Bruce's comment about sharing the difficult registrar across the supervisors, the other thing that's very clear about the difficult registrar is that direct observation with video is an exceptionally powerful tool if it's around their consultations, if it's around the way they're working with patients, etc. And that's definitely been shown to be a really powerful tool. Oh, we'll only let you tick 1. Sheila, I'm sorry about that. We thought that we'd made it more. Oh, there you go. Look, I didn't tick the button wasn't ticked. Oh, well. So it's a real mix across for all of you. It's great to see that most of you are well trained and you feel that that's the area. But there's just some food for thought about which area in all of those protective factors can I actually strengthen. Yeah, that whole concept of having to store the video is a real challenge, isn't it? So I've spent a long time on protective, and we've only got a short time left for managing the supervisor in difficulty. But in many ways, there's a lot of similarities to managing a registrar in difficulty. It's just that you will be drawing on a whole lot of other people within the RTO networks in that. So the very first part, apart from that prevention and protective, is to be going, well, am I seeing things that are early warning signs? And generally it'll be the registrar, but it might be other supervisors or doctors in the practice or other practice members. But equally the registrar might talk to all of these other people, including other registrars. So we might find out about a supervisor in difficulty in a variety of ways. But I think the challenge for you as supervisors is, how do I identify supervisors in difficulty? Bruce, there's been a little bit of, in Victoria, there's been a legal argument that the video is a record of a patient consultation and therefore must be kept like patient records for 7 years. Yes, in the past we've all deleted them, and so this has caused a great deal of angst in at least one RTO because of this perception, and it hasn't been clarified or cleared very easily. Other RTOs are still doing videos, but that is the reason. It's a record of a doctor-patient consultation, and therefore, like patient notes, needs to be kept. So all very challenging there. So there's no surprises in those early warning signs. They're really the same as the ones that are in the registrar early warning signs, and some of the things that you were all talking about at the very beginning. But I think I'd just flag the emotional, that a supervisor, another doctor, who's starting to get quite emotional and will talk to anyone about what's really going on for them and their personal upsets at work or at home, is going to be a real flag. Bypass might be about patients, but in actual fact it's about bypassing by the registrar. And complaints by the registrar, again that may be just small comments, but equally blaming others. one of the common challenges in identifying or managing the supervisor in difficulty is that often it's the learner, the registrar, who is flagged as the problem, when in actual fact it could in fact be the supervisor. Well, that's kept you all going, the video, hasn't it? If you're talking about managing supervisor in difficulty, supervisor at risk, then there are two elements to it. There is your personal response that has a crucial conversation about identifying it, about talking about it, about working with it, getting someone else to support you, and this is something we should be teaching the registrars as well, documenting it, and someone pointed out the importance of documenting, seeking advice from other individuals at higher levels, directors of training, reporting when it's becoming recurring or serious, offering support. Organisationally, keep in mind your organisation is your practice. It isn't just the RTO. So are there formal processes? Have you got fact gathering, investigating it, progressive follow-up, resolution, documentation, and really importantly, support for all. Not just the person who's the victim, but the person who's struggling, and you all know that. As supervisors, you need to be able to do the personal response strategies, but also the organisational response strategies, because you're supervisors. For registrars, it's really important we create environments and support them with the personal response strategies. They're both really important. And when you are managing someone, it's just like the registrar, because it's about staged, it's about progressive management, and it's often dictated by the behaviour trigger. At the very extreme, there's the mandatory reporting. At the other end is the let's have a conversation. And you can see this is a model of a staged progressive approach with ideas of interventional strategies. And this was taken from the Canadians. But much of this is, you don't just do one, you might do a range of these strategies. And if it's low, it's a flag. It's about a crucial conversation. It's about having that behaviour flagged early. And then as it becomes either moderately severe or continuing, then there's more formal components. Way down to temporary withdrawal as a GP supervisor, withdrawal of practice, report to APRA. So keep in mind that these intervention strategies need to come in early and need to be staged and progressive with clear loops of follow-up and seeing things through. And I'll just go back, and the RTO, the SLO, GPSA all fit into those level 1 and level 2s very particularly, with the RTO and the RACGP and ACRM sort of coming in when it gets much more severe. And as I said, it's support for all. So remember that you're looking for your colleagues to identify early so that you can be supported. There's a Doctor's Health Advisory Service in each of the states, and there is the GP support program for the RACGP. It's available only for members, which is a bit unfortunate, but the Doctor's Health Advisory is there as well. So a registrar in difficulty, a registrar at risk, is a challenge. I think there's a real challenge for supervisors. The GPs, so we as GPs are all a bit at risk. As supervisors, you've got a complex, diverse roles, some challenges. So the challenge in terms of supervisor in difficulty, I think, is putting protective measures in place so that you have got a supportive environment, that you are sharing, that you don't have this perception you have to be the superhero supervisor, that in fact it is a whole team that can do it. I think the challenge is actually recognising the early behaviours, but also managing the early behaviours and not letting them get too far advanced. I think the challenge is about recognising it so that going to teaching and really getting your head around some of those more complex areas. And just to reinforce again, that whole issue of the challenge is when you're seeing those behaviours, managing them early. That whole issue of, if I see something happening, even if it's just small things that are minor, don't let them slip by. That's the time to be dealing with them, not when they're big, not when your colleague is stressed, not when you're stressed. Get support, but get involved early. And on that note, I've gone a little bit over and I do apologise, but I hope it's given you some food for thought and some ideas about how you might look at the challenge of the supervisor in difficulty.